Hello, everyone. Welcome to our April Community Health Talk on evidence-based mental health interventions for common mental health problems in primary care. It is my great honor and pleasure to introduce my dear friend and colleague, Professor Samuel Wong. Professor Wong is a clinician with training in both family medicine and public health. He is the director of the Jockey Club School of Public Health and Primary Care, and is also the Associate Dean for Education of the Faculty of Medicine at the Chinese University of Hong Kong. He is a founding director of the Thomas Jing Center for Mindfulness Research and Training. We are also very proud and privileged to enjoy his leadership as a member of the global faculty for the Stanford Center for Asian Health Research and Education. Professor Wong's research interests include evaluating and developing mindfulness-based and mental health interventions in primary care and in evaluating primary care services. He has developed primary care service models as well. He has published more than 200 original papers in peer-reviewed scientific journals, including Annals of Family Medicine, Psychotherapy and Psychosomatics, the British Journal of Psychiatry, and the JAMA Internal Medicine. He's also contributed 5 book chapters and served as a co-editor for the Oxford textbook of public mental health, which is published by the Oxford University Press. He has been appointed by the Hong Kong SAR government as a member of the expert panel in primary healthcare and non-communicable diseases, and is on the steering committee on primary healthcare development. Professor Wong will be discussing evidence-based interventions for common mental health problems. Please join me in welcoming Professor Samuel Wong.
Thank you, Dr. Gloria Kim, a great friend. This is a wonderful opportunity today to talk to all of you on a very important but sometimes being neglected health problems. And because there is actually a very big topic when you talk about evidence-based mental health interventions, with my background, I will focus a little bit more on the non-pharmacological side, and also with the specific issues related to Asians' mental health issues, especially Asian Americans. So this is actually a very nice view of the Hong Kong harbor from the peak. And this is the Hong Kong harbor where there are ships and ferries that has been coming to our harbor for many, many years. And this is the general impression of people of Hong Kong. But we also have other features that are very good for our mental well-being. And this is including some of the beaches and the hiking trails that we have in Hong Kong. So we are not just an urbanized city, but also with many parks and also hills that are very good for taking an outdoor walks, which is not very different from California, I would say. So back to the topics of today. So I'm going to talk a little bit about the mental health problems. This is an issue that is often being neglected by both developed and developing countries, although there has been an increasing burden over the years. And some of the specific challenges and issues to Asian Americans and Asians, and some of the commonalities, I would say, for issues with regard to mental health in the Asian regions, and also in the US, where there are a lot of Asian Americans, Asian families, and with a specific culture-related issues. I will also talk a little bit about the benefits of providing mental health services in primary care and give you some ideas of some of the more evidence-based interventions, focusing on some of the more non-pharmacological interventions, and also some of that which may be more well-known to Asian Americans. So this is a slide that is that I use from the World Health Organizations and talk about the common mental health disorders. So when we talk about common mental health disorders, we in general refer to 2 major disorders that include depression and anxiety. Although depression has some higher prevalence in the general population as compared to anxiety. And globally, there's about 4.4% of the global population suffer from depression. And that varies from countries to countries, regions to regions. And there is a chance, or there's a trend actually, that there's increasing number of people suffering from common mental disorders such as depression. And in fact, currently, depression is the leading cause of disability globally. And also by 2030, the WHO expected that depression will be the leading burden of diseases globally. The things about depression is that it is not just about genetics, not just about lifestyle risk factor, but there are other social determinants that has significantly affect the prevalence of depression. That include poverty, unemployment, stressful life events, etc., and also physical illnesses. So this is a figure showing the prevalence of this depressive disorders by the WHO region. You can see that the Western Pacific may have a lower prevalence when compared to the regions of the Americas. But in general, which is very clear from here, that females tend to have a high prevalence of depressive disorders when compared to male. By age and sex, you see that females still are more likely to have a high prevalence of depressive disorders, although there is a slight trend of people increasing in terms of the prevalence till the middle age, and they tend to improve later in life. For anxiety disorders, there are similar trends, although it seems that the region of Americas tends to have a high prevalence, although the overall prevalence of anxiety disorders is lower than that of depression. Now, this is a slide that I really want to show people. It's about the past year prevalence of any mental illness among the US adults. And this figure, which I found from the National Institute of Mental Health from the US, not only showing the gender differences, but also look into the age differences and also differences among ethnic groups. And you can see that the younger population now have a high prevalence of any mental illness in the US in 2020. This is published in 2021. While Asian populations may have a lower prevalence, although we're not sure whether this is related to differences of reporting or stigma associated with being known to have a mental health disorder. So this is a figure that I really want to highlight. And you can see this is a figure on the mental health services received in past year among US adults with any mental illnesses. So this is the health services among people that already have a mental illness. And you can see the Asian populations have the lowest health services utilization, even though they have mental illnesses in the past year in the US, as compared to other ethnic groups, with the whites or two other racial groups tends to have a higher services utilization, while the age does not seem to have a very significant impact, and females tend to use health services more. Some of the statistics that I found, although this is a little bit old, but still is quite relevant to the Asian American populations. Among Asian Americans, suicide was the second leading cause of death among the people aged 15 and 34. So it seems to be very affected among the younger Asian American general populations. And among all Asian Americans, those aged 20 to 24 has the highest suicide rate. Among Asian American adults, those aged 18 to 34 had the highest rates of suicide thoughts, intent, and attempts compared to other age groups. So it seems that for the Asian American population, being young and also who are in college may have a higher burden of mental health related problems. What can be the factors associated with suicidal thoughts and attempts among Asian Americans? And this is a complex issue, and I believe that although research has been done, this is a more dynamic and changes in the environment, in the social context, could also be contributing to differences in the prevalence and incidence of suicidal thoughts or depression among Asian Americans. But we should take particular attention to the social factors, including the family conflicts and also experience of discrimination, which can increase the suicidal thoughts and attempts. An ethnic group identification, including one identification with its own ethnic group, is a protective factors, and strong family cohesion and parental supports are protective factors. Especially strong family cohesion seems to be very important among Asian Americans and Asian in general. And therefore, if you lose that cohesion or if you lose that parental support, then there might be additional risk factors for creating or making high prevalence of mental health issues. So because of the high prevalence, there are research, or there are a lot of the discussion being done to look into, why does this exist? What's the unique barriers or problems that has been faced by the Asian Americans in terms of the issues. So this is papers published in the medical news today in just 2 years ago, and they look into how are the issues being specific to Asian Americans. And according to the Mental Health America, Asian Americans are the least likely racial group in the US to seek mental health services. So what could be the contributing issues? And this is a photo that is from the news today's. In fact, they are 3 times less likely to seek treatment or help than other Asian groups in the US. So the issues is it barriers to access to care? Is it the stigma among Asian cultures or mental health problems? What are the issues? And are there any research done to look into the issues and to propose some solutions for this problem? So a very, very old article in 2002 have discussed about these cultural factors influencing the mental health of Asian Americans. Initially, that's included language, age, gender, etc. But also some of the work has been looking into the Asian traditional values on the family as a unit, with each individual having a specific role and positions. And therefore, if someone is seeking help, there may be more stigma, as the individual health-seeking behavior might impact the whole family unit or the community unit, which can cause shame of the whole family or the collective, the collective community. In addition, there's a lot of work by Arthur Kleinman from Harvard from many years ago showing that Asian patients are likely to express psychological distress as physical complaint. And these physical complaints can include things like insomnia, fatigue, muscle tension, palpitation, etc., which physicians or healthcare workers may have missed these presentations as purely physical without looking into the psychological and social aspects of the presentation. So this is an article that I found from The Guardian from the UK, published in the 2021, and talking about similar issues. Xin Yi is someone who suffered from depression, and she wrote this article talking about her adolescence when she was combating depression, and she has attempted suicide once, talking about her experience and history when she was interacting with her family, interacting with the counselors, and the fact that there were barriers and difficulty when she seek mental health services, with the resulting delay of getting the treatment because of the fact the family wasn't very open and quite reluctant to face this issue in her. So one of the quotes, "My Asian parents, like many, did not understand my depression and anxiety. But today, talking about how it affected me openly is still treacherous terrain." So she's still receiving some of the denial or some of the shame that is from the family when she talked about these issues. And therefore, when she wrote this article, she didn't use her real name in this. So what could be the factors that affect the underutilizations of mental health services among Asian? So this is a study among 701 participants. Almost half of them are women, and they currently were suffering from moderate to severe depression. So what did they do in this research is that they first look at quantitatively among this high-risk group who did not access any mental health care. And in fact, 60% of them did not access any mental health care, and more than 80% did not receive the minimally adequate care. So in clinical medicine, sometimes we define some of the evidence-based interventions as the minimally adequate care for people with mental health issues. So there's a high prevalence of people in this research showing that they have not accessed or used any mental health services. So why is this so? So the second part of this research is that they look into the specific issues, asking the why questions using qualitative analysis to look at factors that might have contributed to the underutilization factors. Now, the previous, the publication from The Guardian, these are all stories and narratives. So we need more evidence-based research to show the contributing factors using either qualitative interviews and quantitative survey to identify the factors. And there are actually several factors that the researchers have found that may have been related to the underlying underutilization factors. But first of all, in the qualitative studies, they said the Asian family contributions to mental health stigmas, including some of the parents dismissive of mental health concerns. And that is very similar to the article written by written in The Guardian that's saying that when the first time when the adolescents discussed the mental health issues, the parents were focusing on something else and thought that it is a minor issues and did not want to talk about it. So emphasis on saving face. For the Asian community contributions, some of the community will view mental health problems as a taboo subject, and probably they don't want the community to be perceived as having mental health issues and disapprove of burdening the others with problems. And there's also a mismatch of mental health services system with the cultural needs. And in this qualitative research, the participants suggested that, you know, intervention models can be more culturally acceptable to the Asian populations, including having a more holistic approach, including some of the other approach that is less medicalized. For example, well-being approach. And in fact, some of the participants commented that they don't want talk therapy. Thinking about paying so much to just talking may not be very cost-effective for them. And also, they also were asking for practitioners who have a dual cultural experience so that they will have the understanding to help them to understand the issues. The women also talk about how they find alternative coping, which is less stigmatizing, including going for the internet to look for information and use of self-help books, which I believe is pretty common for the psychological health, self-help industry to have flourished over the 10 to 20 years. Unfortunately, some of the women also tend to look for substances to numb the pain, including the use of alcohol and other substances to help the pain, including the use of narcotics. So that brings back to why I would advocate for integrating mental health into primary care, because the primary care physicians know the patients very well over time, and the accessibility is much higher with less stigmatizing when people seek mental health services in the primary care settings. They also may be more affordable and cost-effective, and the physicians with a generalist approach can also look at the issues more holistically without being perceived as just addressing the issues as a treatment model. And in fact, the WHO working with the Wong, which is a World Organization of Family Doctors. That publication was done in 2008. So that has been quite a while back that this has been advocated to be the approach for mental health issues by the WHO. The other benefits of having mental health issues being managed in the primary care settings include the fact that many people who have chronic diseases are also seeing the mental health problems. If they can do it in the same context, that will be much more useful, including the more integrated treatment and the reduction of potential side effects that can be managed in the primary care settings. So go back to the one of the main topics of today. So what are the non-pharmacological interventions that are evidence-based that are relevant or maybe more acceptable to the Asian populations? If you look at any psychological text or most of the publication, including the publication that I co-authored, psychological treatments, mainly cognitive behavioral therapy, now seems to be the mainstreams of evidence-based psychological interventions. So, for example, in Hong Kong, if you have any mental health issues and your psychiatrist or primary care doctors or yourself go directly to seek psychological therapies, then it's very likely that they will use cognitive behavioral therapy. Although this therapy sometimes could be very expensive, and often it takes about 15 to 20 sessions to complete the whole treatments, and each sessions can take up to an hour for each time. So time may be an issue for a lot of people, and many of people, because of that, or the physicians, because of that, they will just prescribe antidepressants for people with common mental health disorders. So I'm going to talk a little bit about some of the benefits of using psychological therapies as compared to antidepressants in treating common mental health disorders. There are also a lot of less formal psychological interventions, including counseling, but the less talked about or less discussed are the interventions including exercise, yoga, well, some of the questions about diet and supplements, which is quite common, and some of the things on acupuncture and qigong and tai chi. So just to recap some of the relatively well-known evidence is on cognitive behavior therapy. And in fact, it's been shown over many times. You see that when you collect 57 studies, there are more than 10,000 population, which shows that CBT is effective for depression and anxiety in different settings, including the primary care settings. And they've shown that CBT interventions may be better provided by a non-physician, and that could be the fact that they have more time to deal with that. And many of them are social workers or psychologists, and tends to the fact that delivered in individual sessions tends to be better, especially with motivation interviewing. Now, because of COVID, many people also asked whether the technology assisted CBT, the things that you can access from the computer for the programs, are equally effective. And it seems that the emergent evidence showing that even technology assisted CBT can be quite equally effective compared to in-person CBT. So this may be especially relevant to the Asian population where people might not want to seek face-to-face intervention right away and try out something if they're not suicidal, and if there's no other safety issues, and if the symptoms are mild and that do not affect them significantly functionally or socially for the symptoms. Other studies have also shown that CBT, in addition to CBT, problem-solving therapy, which is a very simple solution-focused problem solving, may also be relevant in the primary care settings. And also technology-assisted treatment may also found to be effective. So what is the e-health intervention for mental health problems? I feel like I'm obligated to touch on this issue simply because of the fact that COVID has changed many of our way to deliver care. And sometimes it's a balance of having face-to-face versus telemedical care to cater for and to being specific and personalized to to the individual that is best to receive the combination of interventions. So e-health mental health is a generic term to describe the use of information and communication technology that used to support and improve mental health condition and mental health care. And that, looking at that, that could include a lot of things, because you're talking about support and improve mental health conditions. And I'll show you some of the websites that I found to be quite useful, and some of them have evidence to show that it can improve people's mental health and well-being. So we talk a lot about effectiveness in health system research. And sometimes we also talk about cost effectiveness, especially in the US, where there are a lot of the insurance company were looking at the healthcare service provision and looking for care that is cost effective to be provided to patients. So research shown that e-health interventions for depression may have a small effect when compared to other evidence-based intervention, but a moderate effect compared to waiting list. The waiting list is that you're not doing anything and just waiting. So it seems that it is helpful for these people. It could be cost-effective for depression, although there more vigorous research is needed, as you know, this only probably started over the past few years with exponential growth in these areas. So what about other countries' recommendations for treatment guidelines for people with mental health issues? So this is a guideline that I downloaded from the NICE guideline, the National Institute of Clinical Evidence from the UK. And in Hong Kong, we use much of these guidelines as our model of health system are very similar to the UK. And for the first thing they talk about, which often does not receive much attention for people with persistent substructural depressive symptoms or mild to moderate depressions, is sleep, good sleep and structured physical activity programs. And for mild to moderate, they recommend psychotherapy as the initial treatment options and consider antidepressants as alternative initial therapy in some cases. Now, although they said that, it does varies among different health systems of what should be the first intervention. In Hong Kong, psychotherapy is not the first line treatment. In fact, we tend to prescribe antidepressants or some counseling by the family doctors. While the more severe cases are often referred for psychiatrists, or people who do not respond after you use 2 or more antidepressants are referred for psychiatrists. In the private sector, Hong Kong also have a private sector, then people can access direct care to the psychiatrist, although it is much more expensive. So in the public sector in Hong Kong, actually people don't tend to see psychotherapy unless they get referred by the public psychiatrist, which might take much time. In the NICE guideline or in the UK, as you know, the psychotherapy are being paid by the NHS. So perhaps that's why they recommend this as a first line treatments. And for more severe case accommodations, including referring to psychiatrists and even using the electroconvulsive therapy has been evidence-based and useful for people with severe depression. So the optimal medications, I'm not going to drill on that very much, include SSRI, SNRI, and also some of the more atypical antidepressants. So back to the computer-assisted cognitive behavioral therapy for depression. So what are they and where can you find them? So these are the programs. Actually, most of them are in Australia. I'm not sure what's the reason. For example, the Mood Gym is a sort of interactive, computerized CBD program that's shown to have evidence-based to reduce depressive symptoms. Beating the Blues is another quite well-known Australian programs that's been used. And I just give you a snapshot of what it is like to use this program. So I'm not sure how many of you are familiar with the cognitive behavioral therapy concept. Or in fact, we all have adversity in life, right? So for example, this example, the car breakdown. So someone who have maybe a lot less depressive thoughts may think, oh, this breakdown, then I can just find some friends to help. But for someone with depression, they might think that this is the worst thing that could happen. I will never be able to fix the car by myself. There's no one to help me. I would better not go on that trip interstate next week in case the car breaks down again. So they tend to catastrophize and overgeneralize. We call it cognitive distortions, where they will say, they will use phrases like, I would never be able to. So this is something that is implying the future to be the same with no difference. There's no one to help. So they tend to overgeneralize and thinking that without testing it, they will think that no one will be able to help them. And then they will think about the future to be as negative. The car will break down again. So by doing that, they will identify these cognitive thoughts and ask them to do some experiment in their life to collect evidence to disprove or to support these arguments. And then they will report back and fill out some very short question and reevaluate and monitor the changes in the mood. So these are all computerized, and they will have something that can jam up some red flag when people really need to seek immediate psychiatric help. So it seems that computer-assisted CBT will be even for more helpful if there's some support from a clinician or other helping person to work with the person instead of just being a self-guided CBT. But this is exactly, I believe that more research is needed to how to combine these various interventions such that more personalized, effective intervention can be done for each individual. The next I will talk about my favorite subjects is called mindfulness meditations. As you know from the brief introduction, very kind introduction by Dr. Gloria Kim. I'm the director of the Thomas Jing Center for Mindfulness Research and Training. And we have been working with the Oxford Mindfulness Center to provide training for our healthcare workers in Hong Kong, although each training are done with each year only training about 35 people because of the space allowed. So what are the evidence for mindfulness and when should you use that or when should you refer someone for meditation? I'm actually very jealous or actually very envious of the availabilities of many of these well-being centers and services available in California. And there are tons of many centers of mindfulness that I've known in California, including San Francisco, Southern California, etc. So what are the evidence for using mindfulness training? Well, first of all, there are different kinds of mindfulness training. And the well-known one are the mindfulness-based cognitive therapy. So there's this meta-analysis, which is the individual meta-analysis done that collected individual studies data of 9 studies of over 1,000 patients and look at the effectiveness of using mindfulness-based cognitive therapy in prevention of depressive relapse. Now, the focus here is for people with 2 or more previous episodes of depression. I'm not sure how many of you know about this, but for people with recurrent depression, they would need to take antidepressants for life, or they would need ongoing psychological support, including cognitive behavioral therapy. And the reason for that is that minor triggers can cause them to have an ongoing rumination cycle that can produce a new episode of depression. So these folks from Oxford, Cambridge, and Toronto came together and designed this mindfulness-based cognitive therapy that lasts for 8 weeks with 2 hours each week, and look into its comparison with other evidence-based interventions. And in this systematic review, they found that MBCD, the people undergo MBCD has a reduced risk of depressive relapse, with similar to taking antidepressants. So I think this is by far the strongest evidence to show that mindfulness-based cognitive therapy can work quite well for people with recurrent depression, and the effects are very similar to taking antidepressants. There are other studies using mindfulness-based interventions, including a broader frame. In addition to mindfulness-based cognitive therapy, they also include mindfulness-based stress reduction, which is less specific with less cognitive behavioral treatment interventions within it, compared to control for improving general health. And they found that it is efficacious for improved mental health well-being among the primary care populations, including quality of life. I myself have done some studies on this. We actually have worked quite a lot of topics in Hong Kong, including people with mild depressive symptoms, including menopausal symptoms, including people with chronic stress, including the immunity outcomes, also insomnia, ADHD, ASD, and recently we embarked on substance abuse and also elderly with loneliness. So this is one of the publications that I want to share with you. For people who have mild depressive symptoms that we see in primary care, we give them an 8 weeks mindfulness intervention combined with behavioral interventions and compared to usual care control, and shows that during the 1 year time, there are significant changes in the depressive symptoms, and also the incidence of major depressive disorders will reduce by half over 1 year time when they participate in this 8 weeks, 2 hours each week interventions, which they practice some of the techniques they learned over the 12-month period. In addition, there seems to be some evidence to show that it can reduce anxiety, although that is only temporary and it didn't sustain over the longer term. We have also done some work among people with generalized anxiety disorders, comparing mindfulness-based content therapy with group psychoeducation using the CBT approach, and also people who are family caregivers of someone with a significant physical disability, including people with stroke, Parkinson's disease, etc. And we found that people who are caregiving are suffering from tremendous amount of stress, and many of them have depressive symptoms. And we've shown that an 8 weeks mindfulness stress reduction program, but first of all, they can enroll in it, so they're willing to do it, and it shows that there is a reduction in depressive symptoms and an increase in self-compassion for these people in their caregiving responsibility. So there are other alternative interventions that I want to briefly touch on, including exercise, yoga, acupuncture, and some of the dietary interventions that's maybe more common in the Western society, including St. John's wort, which is available in the pharmacies. And also some of the people or patients sometimes often ask about omega-3 fatty acids. So this, I believe, exercise is such an undervalued intervention for mental health and physical health. We mostly talk about the physical health benefits, including the reduction in cardiovascular disease, diabetes, other physical disorders, chronic pain, etc. But not as many people are talking about exercise as something that can improve our mental well-being. And in fact, large prospective cohort studies have repeatedly shown that people who exercise regularly have a significant reduction of risk of having depressions in the later life. And because this is have a lot of research been done, even randomized controlled trial have shown exercise is associated with a greater reduction in depressive symptoms with active control, placebo, or new treatments. So other studies that in primary care have shown that exercise is an effective intervention for depression and may serve as an alternative for people who do not respond to the given treatment. But of course, in the implementation for exercise, there are other challenges. For example, when someone comes with depressive symptoms, they may not want to move. They may not want to get out of bed in the morning. They may not want to see you. So these are the issues that I think we need to think about. And that's why I think that it can also be an adjunct intervention when something to add to the medications or to the psychotherapy that we use in the primary care settings. And some people do ask about, what type of exercise is good? What about aerobic exercise, resistance training? Does it work as well? And research have done this, is published in the JAMA Psychiatry, showing that resistant exercise training was also associated with reduction in depressive symptoms with a moderate effect size. So you only need to treat 4 people to see the reduction effects on depressive symptoms, independent of the health status or the activities they used. But what about yoga? Yoga is quite commonly practiced in Hong Kong, and I believe in the US it would be similar. And I was looking for, this is published in the British Journal of Sports Medicine in 2021, which is quite recent. And the British Journal of Sports Medicine do publish very good papers. And this study includes 19 studies in the review, and they look into the depressive symptoms change among people with other mental health disorders, and show that yoga can result in greater reduction in depressive symptoms when compared to attention control treatment as usual. And the reduction is associated with higher frequency of yoga sessions. Although the type of yoga they talk about, they could not find any specific type. And the research, the majority are hatha yoga that people use in these studies. And you can see that I'm not sure how many of you are familiar with systematic review, but basically you look at all the published data. Some may be not as effective and some are more effective, and you summarize them looking together such that you have a larger sample size, such that the effects that might not have been shown in a smaller sample size can be seen here. And it shows that the yoga do have a positive effects favoring a reduction of depressive symptoms. What about Tai Chi? Tai Chi is something that is practiced quite regularly among the elder populations. And in Hong Kong, you can see them in parks at 6 or 5 a.m. in the morning. You can see all these elderly people, or older adults, I should say, practicing Tai Chi, and some of them practicing Qigong. So this is the systematic review done quite recently. I believe this is also published in 2021, showing that Tai Chi in combination with antidepressants may be better compared to just antidepressants alone. And that can improve the mental and physical well-being, as well as reducing depression and anxiety. And I believe this is a good way to suggest the older adults to use it, because Tai Chi also have fall prevention benefits, and also can reduce frailty, and also can also can improve the muscle strength of the older adults. But what about acupuncture? Now, acupuncture doesn't seem to have as good an effects for depression, but there are some findings. This one, a meta-analysis, a systematic review, showing that acupuncture may be good for reducing anxiety for people with GAD compared to control groups, although they are calling for more high-quality research to validate these findings. St. John's wort, I'm not sure how often people use that. Seems that the research, I still remember when I was a medical student, we are already showing some evidence on St. John's wort. So it seems to be effective, although the problem with St. John's wort is the quality, that sometimes you don't know which brand you should go for. And sometimes you need to look for potential interaction with other medications that people might have used, as there seems to be limited reporting of adverse events in studies published. But what about omega 3 or polysaccharide fatty acids? So far, it seems that it doesn't show to have much evidence, although there are other evidence for omega-3 for your cardiovascular health benefits. What about seasonal affective depression? For light therapy, we know it's evidence-based. What about light therapy for non-seasonal depression? So far, it seems that it has minimal side effects. Although it may be effective, more higher standard or quality of interventions are needed to conclude whether it's effective or not. But again, if you live in California, you might have more sunshine than we do, and you probably would not need this light therapy for you. So I think this is the last slide of my presentation. And I think that when we talk about mental health issues, we need to take a balance. Sometimes we cannot medicalize all unhappiness. I believe that in our life, there will be happy moments and there will be unhappy moments. So how to balance it as a clinicians, as a healthcare providers, as a caregivers, and to know when to refer or when to provide medical cares is really important to, it's a really important approach to deal with these emergent important health issues globally. So the take-home message, I think stigma is quite common in Asian population. That doesn't mean that we cannot do anything. There's a lot of things that we can do for them. And primary care may be an approach to increase access to care. And for depression, anxiety, and depressive symptoms, in addition to thinking about the medications, we can also think about things that is more accessible, including some of the non-pharmacological interventions, and some of them which might be more culturally acceptable, such as mindfulness, yoga, or Tai Chi, that might be useful for certain populations. So I need to acknowledge some of the research funding from the Harvard Medical Research Fund and my research collaborators, which from different parts of the world. And I want to show you our campus, CUHK campus. We actually, we have a big campus on the hill. So if you have a chance to come, you're very welcome. And our school is right here at School of Public and Primary Care, which is next to the Prince of Wales Hospital. And this is our team, which I want to thank them. And again, I want to show you this photo of, I think Gloria loves this photo of a bridge of a CHK campus with a pond, and we have a lot of kingfisher birds around, and all of the bird species there in Taipo. So thank you very much, and this is such a great pleasure to be able to share the research work with you, and I believe that we all can do a little bit more for improving mental health for the global population and also for the Asian population. Thank you very much. Thank you.
Wow, that was just fantastic, Samuel. Thank you so much for doing as much as you do to help relieve and understand and to help us understand the importance of mental health and what we can do about it. This has just been a fantastic topic, and your comments have been so enlightening. We have a lot of questions. First, let me ask you this. How do you broach mental health topics with Asian patients? I mean, how do you even start, especially the older patients?
Yeah, I think the first thing I need to know is to see that person first. I think Asian populations can also be diverse. So it depends on the age, depends on the background, depending on the history. But I think one of the way, if the person is, as you say, the older adults, sometimes I bridge the topics by looking at the physical presentations and the linking of the potential relationship with what's happening in their life to the physical symptoms first. And then by using an approach such as, if you have hypertension, then we will monitor and sometimes prescribe medication to control the hypertension. So mental health illness such as depression are similar. So that this is something that is a disease that we can all work together to reduce the symptoms or work together to help them and support them over time, and seeing what kind of options they would like. So I found that looking into, for example, the fatigue they have, the pain they have, and sometimes the insomnia they have, maybe a good bridge or gateway to go into a deeper background and relationships that they might have contributed to the mental health issues at present.
Okay, thank you. So what you're saying is you're trying to contextualize their symptoms and use that as a gateway and segue into discussing mental. That's very useful. Is there any correlation in your of mental health with first, second, or third generation Asians or nativity?
Yes, interesting. The papers that I presented, actually, they're looking at the second and third generation of Asian Americans, and they found that the adolescents tend to have higher. They continue to have a higher prevalence of mental health disorders, even with the second and third generation. So, and the seeking help tends to be less compared to the other racial ethnic groups. So I believe that there are correlations, including the second and third generation seems to have an impact of them of not wanting to seek help despite having symptoms. So I think that there can be more to be done for these populations to how to make the care more culturally sensitive. Some of the issues, for example, is that some of the the young adults or adolescents, sometimes they seek the counselor from the schools or universities, but when that get known to the parents, they might react it quite negatively for the fact that they might have disclosed some of the information to the families. So I think that some of the education, which is related to how to deal with that in a family context, are important, such that they will get a balance in terms of how and what's the best way to manage the issues, including the family members, which as you know, Asian families tend to be very closely knitted. So it could be a good way that after all these interventions, they may be more open to the parents and to each other, and that can improve the family dynamics. So I believe that this is indeed a specific issues to Asians for the second and third generation.
Is there any evidence that racial or cultural concordance, for example, Asian American women patients and Asian American women providers, makes any difference in the success of therapy for mental health disorders, such as, anxiety or depression?
Yeah, actually, this is as we raised in one of the research I presented on the qualitative studies. It seems the patients do like to have people who understand them, but I haven't come across to any big studies to look into these issues, and that may be something that we can look more into, because there are quite a lot of work in the African American populations and how to decrease the inequality, and they have done that work to show that it's actually better if you have the more culturally sensitive healthcare providers when you provide care. So I think there may be a benefit to that, although I haven't been looking into this particular issues in details, I have to say.
Okay. Are there any cultural considerations when using cognitive behavioral therapy in the Asian population, or is it mainly adapted to use among all populations?
It seems to be able to be used for all populations, from the studies, because all these CBT interventions are published in also Asian countries. And I have personally used it in group intervention. It seems okay. The only issues that I want to bring up is that, I think among the older adults who might not have sometimes a cognitive ability, or sometimes I see patients who are illiterate. They tend to find it very hard to grasp the concept of cognitions and cognitive distortion. So I believe that people might just say that I don't want any talk therapy. I don't believe in that. And then they may not want to use it. But I believe they can be useful. And I've seen evidence to show that it is also useful in Asian populations. So I think it depends on the age and also the cognitive ability and the understanding, because it does require some of the insights for being benefits from that.
Okay. How should care be given to someone who, in addition to being Asian American, might also be part of the LGBTQ community?
Yeah, I think this is also in the written reply. I think the LGBT populations is actually may have more significant burden. In general, LGBT tends to have a high suicide rate and high prevalence of depressive symptoms and substance abuse. Putting that into the Asian context, these people might have more stress, more stigma, and more unique issues that they need to face, especially with the Asian families. So I would think that they will need more help. They might need to have, I would say that more screening are needed in these populations. And I believe they also need some practitioners who understand the specific issues. And I think that some of the role modeling may be helpful for them as well. Yeah, this is an issue that I think we need more work on.
Are there any religious considerations in treatment or religiously based therapies for these disorders?
Yeah, it's interesting because Gloria, you probably will know too that in many of these interventions, we are not allowed to bring in the religious part as interventions, as you know. When I talked to Sindel Siegel, one of the person who created the mindfulness-based cognitive therapy in Toronto, I asked one time, I still remember he was doing training, and in the end he did a bow, and I asked him, is this religious? And he said that no, this is just a gratitude. So he said that in the healthcare setting, they're not allowed to use any of the religious affiliated components within the mindfulness-based training. So it has to be a non-religious intervention. Otherwise, there will be difficulty to implement because it will become an issue when you are providing that in a publicly funded healthcare services. So I'm not saying that the religious intervention will not work. I'm just saying that as a Western doctors, I'm not allowed to explicitly saying that this is a religious related interventions. Although I believe there are other religious interventions that may be useful for people depending on their religious belief. But just that I found that there's less evidence for that because simply that is not studied, and it's much harder to study because they are not as structured, they are not as they may be less incentive for researchers or psychologists to use them because they might face criticism for spreading or advocating for certain religion, and then there could be more issues raised by that. So sometimes I think that lack of evidence doesn't mean it doesn't work. It can just mean that it's harder to do the research. You know what I mean? Like CBT is very successful because it's easy, because it's structured, because it's easy. The components is very explicit. Psychodynamic therapy, on the other hand, is much less research because it could be just that it's more difficult to evaluate. So I think we need to be careful about saying that something doesn't work when you look into the evidence and how you evaluate the evidence. Yeah.
For psychobehavioral therapy, is more better than less? In other words, is there any effect? Are there any studies comparing the effectiveness of weekly versus daily CBT, for example?
Interesting. Most of the research are done because the traditional research with CBT is that they usually meet the therapist once a week, depending on the intensity or severity of symptoms. So, and these are usually individualized. So, for example, in the general sessions, they usually have 15 to 20 sessions for one treatment, for example, for depression. And initially, many of the therapists may see the person weekly for the first month, followed by once every 2 weeks, and then once a month. So very few research, or very few studies or intervention are doing daily. However, I think that computerized CBT can be done daily, simply because you're just doing it at home and there's no other, there's less barriers in terms of the cost, in terms of the therapist availability. I don't think there's explicit research comparing the daily versus the weekly intervention, but I think the computerized psychotherapy may be something that people can look into in the future to compare this. Although it's very hard to have a fair comparison because, computerized is different from a personal, individual, face-to-face intervention. So there will be a lot of confounders between the comparison.
Okay. You talked about mental health issues being more common on young folks, and we all know that adolescence is a particularly chaotic time. So how can one figure out mental health care for kids? And is there a way, for example, to address cause versus treatment, preventive care? Are there programs that could be implemented in the community or within the schools, for example, to reach the most vulnerable populations?
Yeah, I think there are some outreach work that's been done to look at the people with adolescents who are more at risk, and the evidence may be conflicting. So sometimes identifying these people, may be labeling them, and they might not have good effects. I think the better effects may be put it into the more well-being context and integrated that with the normal curriculum. Unfortunately, the UK recently have done a very big research over several thousands adolescents using mindfulness training. So they teach, I think, like 4,000 to 5,000 for adolescents mindfulness training supported by Wellcome Trust, and they couldn't find any effects of using this kind of prevention approach when it's compared to the usual school curriculum. So I think we still need more research in this area. It's just not simple, and it's changing rapidly. So for prevention, sometimes the labeling or the could have another impact on them. So since many of the adolescents is very computer savvy, I would think that the prevention is. Oh, actually, I suddenly thought of studies that done by. Actually, it's done by someone from Stanford, I think. Carol Tuerga. What she did, I'm not sure if you heard about this. It's called Mindset. This book, this wonderful book called Mindset, and looking into primary school or young children who tend to have different mindset. So some people have a fixed mindset versus a growth mindset. not sure if you heard of that. So they devised, this is published in Nature or Science a few months ago. I still remember reading that. They published studies across high school in the US and shown that a very brief intervention of 30 minutes during school, and these are healthy children without mental health illness, can significantly change and improve the resilience among these children by teaching them or by exposing them how do they perceive adversity, you know. So some people, when we have adversity, some people have a fixed mindset thinking about this is all me, this is my fault. It's not going to change, because when you have that attribution, then you think that this is forever because you're not going to change yourself, right? Some people have a growth mindset to think that when they have adversity, then this is because they haven't worked hard enough, because they haven't tried enough. And when they have a growth mindset, next time they have adversity, they will try more, versus the fixed mindset where next time they have this adversity, they will try to avoid it because they don't want to show it again that this is them who causing or who failed. So this growth mindset can be trained with a very relatively short interventions that can benefit many populations. And I believe that is probably one of the first studies or second studies that have been done using a randomized controlled trial design. And I can send it around if people are interested. I still remember reading it with excitement because you just imagine fabulous things that we can do for these young people and how we can change the mindset with very cost-effective public health interventions.
That sounds really wonderful, and I would love if you shared that information.
Yes,
we're at the top of the hour. There are lots.
This is so exciting, Gloria. I'm so happy to be here and answering these questions.
Well, we want you back. Stay with us. But there are more questions, and folks who have submitted them, we will try to get you answers in due course. And I want to thank everyone for coming, and especially a huge thank you to my dear friend and mentor and colleague, Samuel Wong. Please.
Oh, you are my mentor, Gloria.
No.
You're a good role model for me.
No, you know, I think you've really been wonderful to share all of this, and by understanding what makes people sad, let's hope we can teach people to be happy, because yes, unless we're happy, how can we be healthy? So exactly. Everyone have a wonderful evening or a wonderful day, and please join us again in the future.
And thank you for the invitation again. It's been a great pleasure. Okay. So thank you for meeting all of you. Thank you. Have a good evening.
Okay. Bye, everyone. Bye.